No, I knew that. Oh, yeah. I was just
Yeah.
direction.
Yeah, good job.
All right, it is 5 o'clock. We're going to call this meeting to order. This Kittitas County Public Hospital District Number 1, December 4th, 2025. We have an approval of the agenda. We have an amended agenda tonight. Everyone should have. So I will entertain a motion, or if there's any changes, let me know.
Move to approve the agenda as amended.
I second it.
Motion to approve, second. Any further discussion? All in favor, say aye.
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 I too will vote aye. Any opposed? That motion passes. If you've had a chance to read the consent agenda, I will entertain a motion when ready.
So moved.
Motion by Bob,
Second.
second by Matt. Any further discussion? All in favor, say aye.
Aye.
I too will vote aye. Any opposed? That motion passes. So we are to presentations, and we're going to start with Safe Catch Award, and I will hand it off to you, Matt, to, please, go ahead.
I just want to take a minute to introduce Holly Urban. So Holly just started with us on Monday. Really excited to have her with us. Interim Chief Nursing Officer, most recently coming from St. Joseph's Regional Hospital in Idaho. If you want to take a couple of minutes and say anything about yourself, if you would like.
Been a nurse for a long time. I have 4 children and 17 grandchildren. So I have enjoyed and felt very welcome here and appreciate welcome and everybody's provided. So glad to be here.
And I know you've met Matt and Erica, but I don't know if you've met the other commissioners, but Terry Clark on the end. Terry was just reelected this year. So congrats, Terry, on your election. Bob Davis, he's our vice chair. And John was our chair. Oh, yeah. Sorry. Bob was reelected this year as well. And Matt Altman.
Yep.
Welcome, all.
Thanks.
So Matt, I'll hand it off to you.
Okay, so yeah, we're presenting a couple of Safe Catch Awards tonight. As I say, every time we do this, this is the best part of my job because we get to see all this amazing work people do on the floor and help make this good place for patients. Matthew Knight is here, and he's our first he's the clinical award winner. Matthew Knight, RN in Surgical Services. Reason for nomination: recognizing the potential for harm to a surgical patient. Nominated by Mackenzie Collins and Megan McSorley. So here's what happened. A patient was scheduled for an LEEP procedure in the OR. When completing the patient's intake, history, and background, he discovered the patient had an implanted neurosacral nerve stimulator. He questioned and voiced to the provider that he didn't know if the LEEP procedure was safe due to cautery involved. This prompted the provider to consult with the University of Washington Urogynecology Clinic and Medtronic Interstim. It was determined that proceeding with heavy use of monopolar cautery could be detrimental. With the information from these consultations, it was determined that LEP would not be safe for the patient, and an alternative safe procedure was performed instead. If Matt had not caught or voiced the safety concern involving the patient's implant, who knows the harm that could have been involved. Thank you. Award, which I'll announce, but I don't think Nico is here. Nico Moya, Serial Processing Tech, our non-clinical award winner. The reason for nomination was investigating a concerning smell in the department, nominated by Dave Swarry. Nico noticed something smelling like melted plastic in the decontamination room and notified Dave to help investigate. And it was noticed smoke appeared to be coming from behind the ultrasonic machine. Engineering was notified to assist, and after taking a panel off the machine, a hose had burst, causing water to leak and spray on the motherboard of the machine, causing the machine to short out, thus causing smoke and the burnt plastic smell. The equipment field representative was notified and came to service the machine. It is believed this burnt hose could have caused an actual fire if left undetected. So congratulations to Nico. Matt and I are going to step out into the hall for a moment, but meeting will continue. Thank you for coming too. Appreciate it.
All right, so we're going to move on to the department spotlight, behavioral health. Who wants to introduce our?
Yeah, I'll introduce Oren O'Connell. So Oren is leading our behavioral health integrated behavioral health practice. We've since expanded from FMCE where he started to Fairmont Cle Elum and Fairmont Ellensburg, as well as a little bit into pediatrics and women's health, I believe, as well, a little.
Working on.
Yeah. So really excited to see him expanding this program and really reaching the community in a new way that we hadn't before. I think he started in 2019.
17.
Okay, so it's been some time, not a new program, but he's a very developed program at this point.
Well, yeah, we're going to be talking about behavioral health here for the next 10, 15 minutes. You have a number of team members joining me tonight. Very grateful. Honored to be working with individuals. I came to KVH in 2017, and actually I've been excited about integrated behavioral healthcare for a long time. When I interviewed, I actually had an integrated behavioral healthcare implementation guide. At that time, a lot of the administration had no idea even what integrated behavioral healthcare was. So I feel like we're making some good progress. So again, I'm a psychiatric nurse practitioner. I'm based out of Family Medicine, Cle Elum. And although we have a department spotlight, I will highlight the fact that behavioral health, we're actually not a formal department. We're an extension of the primary care clinics. I did want to highlight the team. Integrated behavioral healthcare at Kittitas Valley Healthcare has been built on the backs of these individuals. There are some other individuals who are key supports who aren't listed, but these are the key champions. And actually, we have all of our therapists right here. And within the model we use, their role is defined as the behavioral healthcare manager. Some of these roles are not going to make sense right now, but I'm hoping by the end of the presentation, most of them will make sense. There's a few main areas that I'd like to cover tonight. I'd really like to celebrate the milestones that we've achieved as a team. I'd also like to introduce all of you a little bit to integrated behavioral healthcare, introduce you to the model that we're utilizing at KVH. And then I'd also like to highlight our vision for the future. So first off, why should we even care about behavioral health in the primary care setting? Well, if you're not aware of it already, a good portion of the care delivered in the primary care setting is actually behavioral health. Somebody comes in with a condition, it might be labeled as a health condition, and they say, hey, this is really affecting my sleep. It's affecting work, right? It's affecting my focus. Well, that just turned into a behavioral health visit, right? Especially in rural settings, a large part of our psychiatric medications are actually prescribed and managed by primary care providers. There's a good quote here that I like where primary care is the de facto mental health system. It has been dubbed the de facto mental health system in the United States. The reason I like that statement is because that wasn't from last year, 2020, 10 years ago, 20 years ago. That's actually a quote from the 1970s, oddly enough. The reason being, because if you think about it, a lot of our patients in the primary care setting might start from birth to end of life, right? So primary care is often the first point of care for these individuals when they're seeking mental health support. Another reason that we should care about behavioral health, especially in rural areas, is because there are a number of disparities. Within our population in Kittitas County, there's issues with access as far as transportation. There's higher psychosocial burden. We also don't have as many behavioral health care providers to begin with in our area. This is a little bit small on this TV, but I did want to highlight, obviously, the importance of collaboration as how we get to integrated healthcare, but I really wanted to point out the levels of collaboration. Oftentimes in management, it feels like, we need to hire more of this person, or we need to hire more of that person. It's important to have an adequately staffed team, yes, but that's only the first part, right? When I started at KVH in 2017, I came in at level 2, level 3. We started out with a co-located behavioral health care practice. One of the things you'll notice as you go up in the levels, actually, the outcomes for the patient and the team tend to improve. And actually, we're better able to address disparities as we get to level 6, level 6 collaboration. So that really should be our goal along the way. And so we can't always, hire the right people at the right time. So sometimes the most important way to improve access is to leverage the talent that we already have. How can we work together, collaborate more effectively? And that brings me to our integrated behavioral healthcare program. So how do we get to level 5, level 6 collaboration? At KVH, we've decided to launch the collaborative care model. The collaborative care model was actually invented by the University of Washington Ames Center. Ames stands for Advancing Mental Health Solutions. It's a center within the University of Washington School of Medicine Department of Psychiatry. Why are we using the collaborative care model? Well, I have the luxury of saying I like it. I completed a fellowship in the collaborative care model, but it is also evidence-based. The other thing that's good for us is actually collaborative care model is recognized by Center for Medicare and Medicaid Services. It's really growing in popularity. It's unique for us to, at KVH, say that we're early in the innovation curve. Jefferson Healthcare is also now using the collaborative care model. I think since 2018, I recently saw statistics where the collaborative care models had a tenfold growth from 2018 to 2024. It's really becoming popular and mainstream really because of the outcomes and the improvement, in the overall team dynamics. However, rural areas are really still lacking in adoption of the collaborative care model and adoption of integrated behavioral healthcare as a whole. So we are unique. Pat on the back. We launched the collaborative care model at Family Medicine Clallam in 2020, and then we launched the model at Family Medicine Ellensburg in 2022. Our implementation of the collaborative care model was supported by the Primera Rural Mental Health Integration Initiative, which was a grant that Primera put forward, and it was managed by the University of Washington Ames Center. And in total, from each clinic's participation in that grant, we actually received $490,000 because we did achieve all of our milestones along the way. And that specifically went for staff training, resources for the whole clinic to implement the collaborative care model. I do also want to highlight the fact that as of today, Monday when I checked, we have 198 patients that are enrolled in collaborative care across our 2 clinics. So this is a good illustration that highlights the team structure of the COCM model. And what I want to point out here is treatment as usual usually is between the patient and the primary care provider. And the primary care provider is really trying to shoulder the brunt of that patient's needs and behavioral health care. And we can't always be everything to everybody, right? One person cannot manage, behavioral health on their own. It takes a team. What's unique about the collaborative care model is we add 2 additional team members. We add the behavioral health care manager and we add the psychiatric consultant. This is why we call this a patient-centered team. The care is systematic. The follow-up is systematic, where we're tracking that patient's progression as far as visits, but also symptoms and improvement. And we escalate the patient's care as we need to if they're not improving. The other thing that I just quickly want to highlight, right now, our behavioral healthcare managers are all LICSWs. That role is sometimes a nurse, sometimes a psychologist. We've chosen therapists within our rural healthcare clinics because right now it makes the most sense from a financial sustainability perspective. And I'm going to let Elisa, one of our therapists, take over for this slide.
You may have Elisa Peterson. I am the behavioral health care manager in Clallam and also a licensed clinical social worker. So I just want to highlight for you some of the patient experience in collaborative care. And the first thing I want to highlight is improved access to care. Because it's so easy for patients to be enrolled in our program, their PCP identifies them, they're referred to us, and an appointment is scheduled. We engage people who would maybe not usually seek out mental health care. Another strong part of our collaborative care model is the suicide prevention emphasis. So when a client comes into our program, they receive a full psychosocial assessment, but we also create a safety plan with each client, whether they're suicidal or not. And a safety plan focuses on several things. One, their coping skills, their warning signs that a crisis is developing. It also helps patients identify people in their life that might help keep them safe. And as clinicians, we get to educate people on the crisis research of Kittitas County. So most patients that come to us have a diagnosis of depression, anxiety. There's other diagnoses too, but those are the most common. So we provide brief evidence-based therapy for clients. Cognitive behavioral therapy, acceptance and commitment therapy, motivational interviewing, among others. And the model has also been adaptable to community needs. So for instance, in Cle Elum, early on, we noticed that a lot of the depression and anxiety we were seeing was due to PTSD. And so I was able to gain extra training in EMDR, which is an evidence-based treatment. And now we provide that to our community. And we've seen great outcomes from that in our patients. So during the course of treatment, clients are usually with us for 6 months or less. And during that time, we're meeting with them regularly, but also the clinicians are each meeting with Lauren, who is our psychiatric provider, and reviewing medications, any problems the client's having. And then we send a note to the PCP so they are looped in.
Excuse me. What's the MDR again, please?
I'm sorry, it's eye movement desensitization and reprocessing.
Oh, right, yeah.
It's one of the foremost treatments for PTSD.
Right, okay, yes. Thank you.
So once clients are done with treatment and ready to leave our program, we also create a relapse prevention program or plan for them. And this helps clients identify the gains they've made in treatment and also how they can leverage those to maintain their mental health. So really, they step into our program, they have a wraparound like that you saw in the triangle, and with the ultimate goal of taking the pressure off the PCP for mental health care.
Thank you, Lisa. So in conclusion, I really just want to emphasize, community members or anybody else says to me, hey, we need more behavioral health at KVH. We need more behavioral health in Kittitas County. What are you guys doing here to try to, improve access, improve care? Well, we are really investing in the collaborative care model. And I can tell you that we are committed to sustaining the collaborative care model at Family Medicine Cle Elum, Family Medicine Ellensburg. I also want to just share with you all that we are fortunate to be a part of a study in January. It's a small study where the University of Washington is actually evaluating a fidelity tool for the collaborative care model that they've been working on actually for a long time. It hasn't worked in the past when they tried to launch it, but we're actually going to be a part of the study with our data, and also our behavioral healthcare managers doing an interview to hopefully see that fidelity model, be useful, and also give us a bit of a scorecard on where we are to ensure that we can sustain a good, evidence-based collaborative care model. Additionally, I do want to highlight the fact that collaborative care model, it's a value-based program, but we are expanding billable services with our therapists. We are billing for this care. And, Dr. Thomas and I were recently talking about, hey, we need to do another review to see where the financials are for this. And I think Scott Casey is working on something to share at a later date. Additionally, we are planning to launch the collaborative care model at Ellensburg Pediatrics and eventually internal medicine. Unfortunately, for the last few years, actually, we've been trying to hire as many therapists as we can get, qualified individuals. It's a tough market right now. So there's other creative ways that we could potentially launch the model at these clinics. We really want to make sure we start off on the right foot. we also want to focus on the progress we've already made and replicating at FMS and Cleon, FMS and Ellensburg. So with that, are there any questions?
How large is your group then between Upper County and Ellensburg?
Like how many people on the team?
Therapists, yourself? I mean, how big's
Yeah.
the team?
Team's actually fairly small right now. We have 3 therapists and myself. And so
Okay.
I still, I,
Emotional support humans too.
So who's on the group? Who's on the group? Okay, so those 3 right there. Because before when you turned and looked at that whole group, I wasn't sure if it was everybody. So it's bigger than I anticipated, but no, this is good. This is great.
How big's your caseload? How many people are in the program?
Is that
Yeah.
the 198 or thereabout?
yeah, currently we have 198. As far as, total patients served, it's about 1,000. It's a little bit over, but we haven't actually compared the data exactly with Cerner. So there could be some doubles, but yeah, we since 2020, we've served at least 1,000 people.
Do you serve more in the Upper County or down here?
Well, Family Medicine Ellensburg does have more primary care providers, is a bigger clinic. It's a little bit of a complicated question because I still have a co-located practice up in Cleon, where somebody will send a referral for, mostly medication management, or if we're not sure of diagnosis, I might see somebody in person. But we're really moving more towards the collaborative care model as much as possible because it's a better use of me as a resource. But right now, as far as the collaborative care model, we have 2 therapists at FMS and Ellensburg, so they do have a higher caseload between the 2 of them.
So what triggers this part of it? You're in senior primary, something you say, a question the primary asks, what opens the door to say, I've got a group I need to put you in touch with?
Yeah, absolutely. So we have a program vision where we ask the primary care provider, we have obviously validated measures specific for depression, anxiety. And we're really trying to encourage the primary care provider to always make sure that we're capturing those measures so that we don't miss symptoms. But if the primary care provider has somebody they're concerned about, let's say it's an immediate crisis, well, we might go grab, our therapist, bring them into the room, do a warm handoff right then and there, get an idea of risk. At that point in time, the therapist might introduce the collaborative care program, or the primary care provider's been working with somebody and they're just not getting better. And a lot of times that will activate the referral to the collaborative care program. But what we ask in an ideal world, we want patients to meet a certain threshold, obviously. And then we also want them to have at least one treatment failure, whether that was a medication or counseling before. We also preface our vision in saying, hey, PHQ-9 or GAD-7 above 10 or based on clinical judgment.
Interesting. It was noted Upper County PTSD is one of the main issues. Is without obviously getting to HIPAA stuff, is there a reason that is a primary issue in Upper County, or
Well,
is it military people or?
I think there's more options for treatment in Ellensburg for people with PTSD. So there's really in Cleon, there's myself and one other clinician that's in the community who doesn't treat PTSD, I don't believe. So I think people with PTSD tend to gravitate towards small communities. But there's a high psychosocial burden.
Yeah.
For Ken.
When someone's in crisis, right, show up at the ER, then do they try to link you as soon as possible? Or is it like, hey, maybe he needs to find, some kind of respite care or some other facility, right? What's your experience with?
Yeah, it's a good question. So usually we don't work directly with the ED at all right now, and it's a little bit of a different focus because we're not specialty behavioral healthcare. We're really going after common mental health problems, right? Chiefly anxiety, depression. However, when that person comes in their primary care provider for a follow-up, they're often then getting referred right to the collaborative care program. Absolutely. And then, when we have seen that, I don't have good data to share with you right now, 5 years ago, actually, Dr. Thomas did a data dive and saw some interesting trends. We're really focused on sustainment, obviously trying to provide good care in what we're already doing, but that is an opportunity in the future for sure.
Other questions at all? Oh, we really appreciate you coming in today and educating us on what you guys do. It's fascinating. I really appreciate everyone's dedication because like you noted, I know in a small community, it's be able to offer this service is really amazing. So thank you for all you do. And anything else for us before?
Well, thank you guys for the opportunity to share. Yeah, I look forward to sharing again. Hopefully not in 5 years. But
Yeah.
Awesome from this group is, we started it from nothing. We're probably we're probably the first rural hospital in the state to bring this model here, partnering with Primera, had the incentives of $250,000 grants, and they brought it to a fully sustainable, financially sustainable program. Really fortunate that we can even do tele care as well, and it's reimbursed the same for behavioral health, like all other services. It's a strategy for reimbursement. So awesome program, and it's financially sustainable on top of it. So, thank you.
Great, yeah, thank you very much. So, so if that's the end of the presentation, feel free to escape if you want, or you're welcome to sit through the entire board meeting. Thank you all. All right, we're moving on to section 5, public comments and announcements. So if anyone from the public wishes to speak, identify yourself and
I'll jump in there real quick.
Okay.
Hey, so I want to begin with nothing in the July 24, 2014 bylaws and nothing in Washington state law prohibits from engaging the community, the board, from engaging with us. Nothing prohibits you from answering questions, even though you say you can't answer questions, and nothing prohibits you from holding a town hall. Just want to get that out there. So if you choose to interact, not to interact, that's exactly what it is. It's a choice on your behalf, John. So if you decide to do it, you can do it. If you don't, then that's your choice. Since October 23rd, 2025, when we went to executive session, you told the public it was the first time you heard about discussed about the deal. From that moment forward, you've been avoiding public dialogue. You've been avoiding me, PRA requests, town hall requests, everything. Got no response. So first, I'd like to go over the October 14th NDA involving former CNO Deb Callums that you issued to her and the HR was part of. The NDA produced through the Public Records Act appeared to be a violation of RCW 4944-211. It's called the Silence No More Act. So it attempts to restrict disclosure of retaliation, discrimination, unlawful conduct. You can look at me. So here are the questions. He's looking away, acting like he's disinterested. So here are the questions I'm going to require direct on the record answers, and you can answer or not answer. Was this NDA reviewed for compliance with RCW 4944-211? You can answer or no.
as I've said before, we as a policy don't enter into dialogue during public comment. We welcome the public to offer their
When you
thoughts.
do it.
And
Requested
and you
PRAs.
talk about personnel matters, that's certainly something we don't talk about publicly.
Okay. Did legal counsel warn you the board, the restrictions with board and unenforceable? It's public record. I'm gonna get it one way or another. If the NDA is unlawful or defective, what corrective action is being taken? No answer. Still not gonna answer.
It's public comment,
Okay,
not
so here's
public
the plain
dialogue.
truth. So if you fail to ensure legal review, it's negligence. If you knowingly use an unlawful NDA, then and repeated false resignation narrative that everybody was saying that she resigned, it's misconduct. So second, the board's description, she resigned narrative. The PRA clearly shows a separation agreement and NDA dated October 14th. Knew about it. You still, the KVH, no voluntary resignation letter was produced. I don't know if there is one or not. You're holding it up, your legal team, whatever. I've already paid the money. I've already requested it. Still nothing. Yet repeated public assurances that the CNO resigned, which is not the case. So the question is simple and unavoidable. Why did the board knowingly create and continue promoting the deceptive narrative that Dr. Collins resigned when your own documents show she was separated under NDA? And you're just gonna sit there and not say anything.
You understand the board is governance. We're governance.
Yeah,
So,
for him.
yeah, exactly. And so we deal at the governance level. So again, is your opportunity to make public comment.
Okay,
For some reason, I don't know why you're worried about a personnel issue. It's strange, but.
yeah, it's
And-
strange
and
if
I
somebody
noticed
gets
that-
released.
I noticed that all of your NDAs appear to be written by artificial. I mean, they follow the same format. It's like you put something in there and have it spit out all your questions. for
Did you get a legal
So
review on
so
it?
it's fascinating.
You
but
said you can't talk about it, but now you're talking about it.
I'm
Did
not-
you get a legal review?
I'm not talking about it.
Public hospital district cannot tell one story to the public while its internal documents show another. So I just want to warn you, this clearly raises legal concerns under RCW 42-23-070. It's called the misuse of public office. RCW 42-20-040, official misconduct. Third, ongoing avoidance and transparency. The PRA response has been delayed. You've restricted, retroactively charged, and I paid, no problem. I'll pay the $4 and released only to non-searchable formats, 508 compliance. You have to abide by federal law. I wanted a searchable PDF format where I can get it, not just a copy or a picture of it. Requests and record a town hall have been ignored. You just, nothing, just follow, just nothing goes into a black hole. Question presented in public meetings here goes unanswered. Just want to ask you real quickly, if a community cannot get the information through PRA, can I get answers in this meeting? Can I get answers in a town hall? And how exactly are we supposed to understand the major decision in taxpayer-funded hospital district? We're just in the dark over this.
There's no organization that will give you personnel information.
I guarantee you I'm gonna get it through a PRA.
Yeah, I have.
This
no
matter
issue
looks
with you submitting
intentional
your
and
request.
concealment.
Huh?
It's intentional concealment, not transparent. I got the NDA already.
We've given full authority, give every document.
So
you
why
want.
don't you have a town hall so I can ask questions, be open and transparent about it?
It's not something we do at this point. This is the opportunity for you to speak.
And it does what? You don't document it, you don't follow up on it. We're just talking about it. I just vent. You're my therapist now.
Your
or
whole
what?
mission seems to be to attack this hospital. Why would we?
Anybody, I just want the
Trying to
information.
The hospital, it serves no
So
purpose.
first, the community expects from you
If you want me
tonight
to speak,
was
do
in
not
October
speak over
14th.
me.
Hang on, I'm talking. 14th,
You have 1 minute.
October NDA review for compliance. It was lawful or unlawful. You're not going to answer. Does this voluntary resignation letter exist? I'd like to see it. I can request that. It's public information. I've already requested it. I haven't received it.
30 more
Correct?
seconds.
Hang on, let me ask the questions. If you're going to answer it, that's fine. But if you're not, don't interrupt me, please.
20
Will you
more
correct the
seconds.
public narrative to match a document of record and acknowledge that Dr. Collins was forced out under CEO's direction, the board's silence and action made complicit? You're part of it. Are you going to schedule a town hall?
10 more
Are you
seconds.
going to schedule a town hall?
Thank you for your
And then
time.
What
Time is up.
safeguards are being implemented to prevent the
Sir,
CEO,
Sir,
board of
your time
commissioners?
is up. You've had your opportunity to speak.
So wait a
publicly.
second, there is nothing in your bylaw. I searched all the minutes and there's nothing. That 3 minutes is your deal.
Yeah.
Let me finish this up.
And as the
Let me
person who
finish
runs
this.
this meeting, I'm
Let me
allowed to
finish
set
this, please.
parameters.
You don't enforce it on anybody but me. So were the safeguards being implemented to prevent the CEO, the Board of Commissioners, KVH legal counsel from misusing public office and public funds? And last, if the board is going to reinstate the CNO, given the apparent illegality of the NDA issued by the CEO and the complete absence of any resignation letter, any, you just blowing it off and ignoring it, or you taking any action?
We'll see if he's done yet.
I'm done.
Okay,
Go
thank
ahead.
you for your time. Is there anyone else has any public comment tonight? Please.
I've been here to speak on this issue before. My name is Connie Johnson. I'm an ER nurse. I've been at KVH for over 12 years with 4 years of ICU experience previously in larger metropolitan hospitals. Last 12 years, I worked days, nights, and I'm currently on mid shifts. I participated in various leadership roles and I'm within the ER, and I'm part of the sexual assault nurse examiner team. And I'm also currently sitting in the union negotiating team with WSNA as we work towards a new nursing contract. Again, I continue to work here because KVH remains the employer of choice due to geographic location. And over the last 6 weeks since Deb's departure, I have unsurprisingly remained disappointed by the administration's response. They continue to claim she resigned, even though all evidence, some of which is being withheld, despite public record requests, shows she was fired. As I mentioned before, this organization claims transparency is a core value, and her firing and subsequent actions by this organization are nothing or anything but. The culture of this organization is toxic. It has been for a long time. The administration is aware. They have been throwing things at the problem for a while: gym discounts, art classes, and even mandatory education on just culture for staff. While the gym discounts and art classes are nice, if the organization did any reflection on who's utilizing these benefits, they would see that the majority of staff who have taken advantage of these perks are clinic and administrative staff. The organizational disconnect from hospital to clinic staff and hours are not surprising, is vast and disappointing. I mentioned just culture. I'm pretty sure the members of our senior leadership team could use a refresher on what that is, so I'll offer an abbreviated in-service on the concept. Just culture, a system of shared accountability that balances holding individuals responsible for their choices with the organization's responsibility to create safe systems. It fosters a blame-free environment to encourage open reporting of errors and near misses, which helps the organization learn from mistakes to improve patient safety rather than punishing unintentional errors. A just culture is a shift from a blame culture by focusing on system design and management of behavior while still distinguishing between human error, at-risk behavior, and reckless behavior. Key principles of a just culture include shareability, open communication, trust, focus on learning, and a systems approach. This works in practice by categorizing behavior in an organization as one of three things: human error, which includes unintentional slips or mistakes. The response would be a simple dispatch or waiver. At-risk behavior, where someone takes a known risk or deviates from safe procedure without recognizing the risk. The response would be coaching. Thirdly, reckless behavior, which is a conscious disregard for a substantial or unjustifiable risk. The response to that would be punitive action. The last tenets in this are that the processes within the system are fair and transparent, and that there is a commitment to continuous improvement, where errors and near misses are used to identify systems issues, close gaps, and make the organization safer for future care. When looking at this model, the number of times this organization deviated regarding Deb's departure would take much longer than my allotted time. However, there are a few points to highlight. Regarding quality, Deb brought her experience in successful healthcare systems that are recognized by nursing organizations as the top providers of care, also known as magnet centers. She also brought an academic background that none of our senior leadership has, which is that she was doctorally prepared. With that experience and 10 months of asking questions, talking to the ground staff, she was able to recognize what she found to be at best human error, at worst risk behavior at the highest levels of this organization. Obviously, this is concerning given the nature of the services we provide. She proceeded in good faith to alert the organization of major failures in CMS documentation and reporting, possible HIPAA violations, lack of a utilization review committee, which is required by Medicare, and more. As a true leader, she not only identified the errors, she came prepared with an action plan to put systems in place that would have perpetuated these errors. Unfortunately, the organization did not act responsibly. They did not take accountability and attempt to correct and deliver care. They did not foster more open communication or trust of Deb or her staff. They did not focus on learning from someone with more experience, and they definitely didn't look at the systems in place as responsible for these failings. In fact, they did the opposite. They decided to fire her. Even if the senior leadership team felt that her assessment was inaccurate, there was coaching or a stepped improvement plan. Neither of those were put in place as one of the key tenets of just culture. She was just fired. This leaves the rest of the hospital and the community to assume that instead of a lack of knowledge or human error, or even at-risk behavior, the hospital is participating in reckless behavior. They attempt to cover up their egregious and possible illegal behavior by firing her is deeply concerning. The nurses and staff at KVH have had enough of being ignored. We have had enough of delivering mediocre care in an organization that can do better. This organization can move swiftly when it decides it wants to. During COVID, it opened a freestanding COVID in 2 weeks. It fired Deb overnight. There is no excuse for not moving quickly to address our concerns. It's been 6 weeks. We continue to come to these meetings. We will continue to hold you all accountable. We demand meaningful and measurable action.
Thank you. Anyone else like to speak?
Yes, I'm Danielle Crawford. I want to begin by acknowledging Debbie Callums, as we have here today, our former CNO and a transformational change maker. It has become clear that her departure was not a voluntary resignation, and yet staff has still not received a transparent or truthful explanation of what has occurred. Since that decision, many employees have experienced ongoing fear, disappointment, and confusion. We continue to see a lack of transparency, actions that feel retaliatory or psychologically unsafe, and a level of mistrust that has grown more than ever before. It's important to say that these are deep-rooted and extend far beyond what we experienced with Debbie, as Hani just spoke to us about. We also need to be honest that we cannot simply carry on Deb's vision. Deb's vision was uniquely hers. A new leader will have to bring their vision, their own direction, and their own values to this organization. We can't ignore the actions of KVH leadership that have drastically affected Debbie and her family. We as an organization exist to heal, yet in this situation, instead of healing, we've caused harm. This must be acknowledged if we are going to go forward and move with integrity. I'd like to speak to the community too, and I hope that you understand that these are not simply internal issues, that this culture inside KVH directly affects patient safety and quality of care for our families and neighbors. Your mom, your dad, your brother, your sister, your son, your daughter. Every family member's care is directly affected by what we've been describing to the board and to the community over the past couple of months. We are not consistently meeting best practice or standards of care. Nursing directors, including myself, are carrying workloads that are so heavy that limit our ability to lead effectively and ensure that the level of care we provide to this community meets those standards of safety and expectations of quality. I stand firmly with our WSNA nurses, with our Teamsters, divisional coordinators, techs, and hospital staff who fill the ongoing gap without Debbie here. I do thank Holly for coming in to help us during this period of transition. Our concerns are real, their voices are real, their well-being directly impacts patient care. Our nurses alone make up about 2/3 of our workforce, and when they feel unheard or unsupported, the entire organization and community feel it. It's equally important to acknowledge that the steps that have been taken so far by the board and by the C-suite have not addressed staff concerns or the organization's needs. Leadership has not acknowledged mistakes. There are ongoing attempts to reinterpret staff concerns to fit a preferred narrative, rather than responding with transparency and accountability. When I first spoke out, I had many employees come to me, some that I did not even know, privately, to thank me for standing up for them and to be the voice that they felt that they could not have, to have that voice. Some even reported receiving anonymous messages that they felt were threatened. And I continue to observe behaviors that many staff experience as intimidating, and this is not compatible with a healthy workplace or a just culture. I want to note that there are those who want to speak out, but they've seen about the mistakes that they've seen, but they have seen the pattern. They've seen the retaliation. They've seen people that have come and gone as Deb, and they're scared. I quote Peter Drucker, who's known as one of the organizational fathers of modern organizational management, who said, "Executives owe it to the organization and to their integrity to tell the truth. Nothing else works." Right now, many staff do not feel that they're being told the truth. Without truth, there can be no trust. And without trust, we cannot ensure safe patient care. For these reasons, I'm asking the board to take this situation seriously, to demonstrate true independence, and to initiate a transparent third-party review of leadership effectiveness and alignment with organizational policy, state and federal laws, and just culture principles. It's essential to restoring safety, trust, and credibility at KVH for our employees and for our community that we serve. As Peter Drucker also said, the greatest danger in times of turbulence is not turbulence. It's the act of yesterday's logic. We can't hold on to the ineffectiveness of leaders without fear of admitting mistakes. True accountability to our community means owning these mistakes and correcting them swiftly. As we move forward, we must not choose familiarity over transformation. Debbie was pushing for high change, and we can't cling to an old regime at the expense of our progress forward. The path to true accountability and transformation at KVH.
Anyone else like to make a public comment?
Hello, my name is Kara. I know most of you guys. Again, I was born and raised in Ellensburg. I've been a nurse here for almost 17 years. I am a union chair representative, and I'm just here again to ask you for accountability and to be people to be held responsible for this and to change the culture of this hospital. I stand 100% behind what Hani said. We need change and we need it now. Thank you.
Anyone else like to speak?
I just actually have nothing to say about any of that, although I'm here to support. What I do want to say is this is Chelsea Collins. She is my new manager in our clinical excellence department. And I'm really happy that we are moving forward with getting education to the people that need it. Thanks.
Anyone else like to have public comment tonight? Andy, can you tell if there's anybody online that wants to speak? Anybody online, raise your hand or identify yourself.
In the chat.
Okay, hearing none, we will conclude the public comment and go on to item 6, reports and dashboards. So first up is quality, Mandy Olson.
So my report starts on page 17. I do have one addition to my report. I talked about our DNV survey and that we had received notification that our objective evidence had been accepted from our last survey. And so that meant that we are recertified with CMS conditions of participation as a critical access hospital. But just this week, we're notified that as our 4th year survey, this also means we are now ISO 9001 certified, which is one of the benefits of being part of DNV instead of the Joint Commission. Is you're not only compliant with the conditions of participation, but you are certified in this international quality management system, which really focuses on continuous quality improvement, proactive, quality-driven culture, not just a compliance-only mindset. And because of that, that's why they survey us every year. It shouldn't be that you're only survey ready every 3 years, like the Joint Commission. So we're really excited about that. And that's been 4 years in the making, and we're really proud. We finally got that notification and certificate.
I think we received it yesterday, so it's really exciting. I've been waiting and crossing our fingers for that, so really excited to see that come through. And 4 years in the making, probably a 5th year of planning, changing from the Joint Commission over to DNP, so it's super exciting.
Yeah, it also certifies our rehab services and our provider-based clinics, which at the time of the survey was only general surgery vascular, but they are also can claim that certificate. They're surveyed as well during our hospital survey.
Is it common for a hospital of our size to receive this certification?
There are quite a few in Washington State that are DNV. I think Prosser kind of went, or not Prosser, excuse me. Pullman was one of the first hospitals that I heard of that had done that. But there are quite a few in the collaborative now. And it's nice because DNV does have a way to collaborate too with all of the other critical access hospitals in the nation. And so we can learn from each other and get best practices or tools, and a lot of learning and sharing that we didn't have when we were only certified through the state surveys.
And the lab is still the Joint Commission.
Yes.
Certified.
Other than that, which is not a small thing, but I don't have any other comments about my report, but I'm happy to take questions.
I want to do another introduction of Jesse Melanson sitting over here. So Jesse is clearly not Stacy Olea. So Stacy is off to Costa Rica, and Jesse is doing a phenomenal job sitting in for Stacy, helping keep all the clinics running and forward, and all questions answered going through Jesse. So thank you. It's been good having you supporting them.
Thanks, appreciate it.
I was going to ask, at the time of your report, you said 92% compliance with the influenza documentation stuff. I don't know if that's changed since
Only
then.
by 1%. So we're 93% compliant with documentation. So documentation, whether people are immunized or declined the flu vaccine, and the rate of vaccination is the same still, 86% vaccination.
And so what happens to that missing 7%? What?
They are getting texts and emails, and their supervisors are getting emails every 4 days about those staff. where we found a challenge is with folks who get their vaccines like from a pharmacy or somewhere else, and we're trying to help get those
Import
records.
the information.
Yeah, and some places don't give really great records back to you when you go and get your flu shot there. So
So then do they wear masks or something, or is there, it's something
Yes.
that's involved in solving?
if someone's not immunized with influenza during the flu season, they need to wear a mask when they're in any KVH facility. Mhm.
Any other questions for Mandy? Else for us? All right, we are on to Chief Executive Officer Jason.
Yeah, thank you. My report, page 27, I just had a few things before this I was writing down because it hit me this morning. Meeting with Jennifer and Bonnie. Bonnie's like, wow, it's December already. So December is my 1 year mark. So I just wrote a few notes to share in it. But on my board report, first paragraph there, just really excited for next year with some new services lines that we're working on, podiatry, urology, and nuclear medicine radiology services as well. Kimmy is really spearheading with Jonica. So next board meeting, you'll probably have a presentation from Jonica on nuclear medicine opportunities that we have. Access to care. So recruitment has been just huge over this last 11, 12 months. And we've been highly successful with recruiting, retaining, and filling a lot of open provider positions. Excited to announce Holly in my report there. So welcoming Holly to the team, really excited to have her and her leadership experience. So thank you, Holly. And thank you to the board for all the houses we have purchased over the years. So we have been using them very well for recruiting. Chelsea, who you just met, is in one of the houses, Jennifer, Holly. So we're using this houses very well, and it's such an asset having them to help bring people here. Construction, we finished the ortho general surgery and moved them in. Cleolum working through Midtown Depot. Just commend Rhonda for her leadership, bringing up the Midtown Depot therapy services. They are hanging sheetrock in there already. I was working at a swift pace, and we anticipate equipment and stuff should be like mid-January, I would think, end of January, start moving into that Cleolum therapy space. So look forward to giving a tour of that new space as it gets completed. And then after that, Jennifer Reed's working with who's Design West. Design West on architecture and engineering services for Radio Hill to renovate the other 10,500 square feet of that and expand the parking lot and work through property lines with the neighbor and come up with even adding in a couple more parking spots. So every additional single one helps. A longer parking spots, not new ones, just longer. Since there's a lot of big trucks here, that does help.
So we finalize that with the neighbor?
It's
or-
with the neighbor's attorney, and he said he was gonna have it done before Thanksgiving, and I haven't heard, but I haven't heard any naysayer either, so I think we're done.
Washington State did volunteer to participate in the Medicare Wiser program. So a program that Medicare is implementing to use AI for prior authorizations for a limited number of services. So that should be fun to navigate. And then just the community relations department, KVH was awarded $105,000 grant for cybersecurity infrastructure. Thank you, Crystal and IT team for all their work to help get that grant. And Crystal continues applying for more grants. It's been a really good funding source for us. We've been highly successful in that grant work, and we had that awesome presentation today, which did start from $500,000 grants. Crystal's team's been doing just some public blast to let the community know of some new providers that we've been starting. I don't know how Crystal's been able to keep up on them. We've got a lot of new providers coming on this quarter and the next. So I just did a few there. Kelly Beanie at ENT, Dr. Brian at OMT, Dr. Sierra DeLay at Family Cleolum, and Dr. Holly, our new general surgeon that started last month. And if you have any other questions on the board report, happy to answer some questions. Otherwise, just wanted to take a few and reflect on this last year. So just some random bullets that I took out of my head before this meeting, no order. Probably missed a lot of things, but first, just thank you to the board for the opportunity to lead the organization and the efforts and support that we've accomplished this last year. It's been fun. I inherited really an awesome hospital with awesome administration. I thank all previous administrators, previous boards for what KVH has here. We are one of the few last standing independent public hospitals that is also very financially stable, and we are growing rather than contracting. That note, East Adams Hospital, another partner, Critical Access Health, will potentially be closing its doors forever in January. And I anticipate there will be more critical access hospitals in the state that will be closing their doors. Hopefully not in 2026, but I would not be shocked if some don't make it to the end. I don't know if you have others seeing on the horizon there, but there's a few that are really struggling. Prior admin managed huge things just a few things I remember that I got to inherit or that prior administration went through. COVID. The MAC building was huge. Family in Cleveland was one that stuck out of me. It's flooding when the main water line in the ceiling burst and there's 4 inches of water through the whole clinic. Snowmageddon was one a few years ago. So just things that are out of our controls that the prior admin got to manage, and then I get to take it forward. This year, some celebrations, just absolutely huge, and thank you to the community, the whole community, for passing the levy, and all staff and peers and friends who helped us get the levy passed. Those are a huge stabilizing factor for our organization. I have no doubt our meetings will be talking about program cuts. Where can we restrict? Where can we get smaller? Where can we eliminate services that are at large financial losses? And we are seeing those. Labor and delivery, hospice services, home care services. These services are going to be closing and are closing at neighboring facilities. And we are not having those discussions. It's absolutely a huge win. We completed the hospital expansion, adding 15,000 square feet and renovating another 15,000 square feet. Kimmy gets to really enjoy that new space and new equipment in there. We had our first day on June 18th, running 3 operating rooms versus 2. So that's the first day in KVH's history. We're doing more surgeries than we ever have. We have a redundant CT machine. So if we are down a CT or it does do general maintenance, we are not on divert. We had a water line blowout in sterile processing as that was wrapping up. That was interesting, and surgical department was able to navigate it seamlessly without disrupting any patient care services. Huge shout out to Dave Story, Nico, and the central sterile processing team through that. Shout out to HR for all the recruiting efforts. So the first thing that I did when I got this role is I moved provider recruiting under Janine. Janine's been an awesome leader of HR recruiting, partnering with Dr. Thomas and really all the providers for recruiting a huge amount of providers. So we've filled 26 provider seats in the last 11 months or offer letters signed. Some of those are a lot of primary care, rapid access, general surgeons, vascular surgeons, ENT, 3 cardiology providers, and a lot of other primary care. Labor and delivery, we have 4 physicians now where we did have 1. I don't think the community is anywhere nearly aware as how close we were to closing labor and delivery services forever if that happened. And now we have a very stable labor and delivery program. I want to call out Sarah DeLay just because it's the position that I got the opportunity to interview as CEO. I just heard she was living in the Valley and called her and came in, interviewed, and she started last month. So that was really awesome to have Sierra welcome to Franklin Cleveland and expand that team. Expanded commitment and partnerships with new contracts agreements with Emergency Associates of Yakima, Evergreen Anesthesia, OnRad Radiology. Shout out to Dr. Jensen, who's our on-site radiology, which is also pretty unique for a critical access hospital to have that skill set of a radiologist on site. And Airlift Northwest with a new preferred provider agreement, and then new collaborative networks with KVFR and Full Health Pharmacy, moving to start a new pharmacy up in Cleveland. We refreshed the strategic pillars. Thank you to the board for all your input and helping us through that. We have onboarded a new courier service and a new GPO and materials management. So you'll see a lot of financial savings in our budgets around materials because of the good work Tony and Jennifer's team are doing. Even though we've exceeded our budget by about $22 million in charges, our total supply budget is right at budget. So we've done a lot of growth and we are holding our expense pretty well. We hired some amazing new leaders. So Dr. Thomas accepting the Chief Medical Officer role. Jennifer Reed as CFO, Crystal Bensley for marketing, Trent, we have Sarah May and EVS, Amy Bloodsworth for cardiopulmonary, Jackie Morris and Jay McDonald and home health hospice. That's just off the top of my head. I'm sure I'm missing some others. We've got 2 new ones in clinic management. So there's a lot of other new leaders and amazing new staff on top of that. So that is HR's work in 12 months on top of lots and lots of other stuff. We started and completed the renovations for general surgery, vascular and ortho, and moved orthopedics back on site and expanded that and added an additional provider. They love the new space. It's beautiful. If you didn't get a chance to tour it, I would take you over there and you could tour. Oracle IT, everything is just IT driven, so I couldn't leave them out. Few little things to note. But I know there's a lot more. We implemented the unified consumer communications, which might sound like a small thing, but it's the text messaging where we can interact with patients and do patient reminders and actually have back and forth. Implemented that, new service line breakouts. So new service lines like ENT, cardiology, neurology used to be embedded into larger clinics like internal medicine or FME. Those are all broke out as separate Cerner platforms, and it's way easier for us to do reporting, see what they're working on, and then also amend that Oracle in that platform to the practice. And a full VoIP deployment. We're in the middle of the Cleom therapy expansion at Midtown Depot, as I noted, plus Jennifer working on Radio Hill expansion for next year. And then in 26, we are really looking forward to bringing on podiatry and neurology services to KVH. So we have such strong momentum to that. And on top of that, we contracted from that presentation with the urology group. And we're also running side by side to recruit a urologist. Janine took on the charge of trying to recruit a urologist and challenge because our contractor group said, yeah, good luck. And we have a candidate tomorrow that we're listing for a urology search head for that. And then the last one to note that we just yesterday received that certification from DNV and ISO 9001. So it's been a heck of a year, and thank you for the support. And thank this whole team and the organization that's here and not here for all of your work.
Any other questions for Jason? Hearing none, we'll move on to Janine.
Well, just tacking on to the position recruitment, I just want to be very clear. It is cat burning all day long. All I do is remove the barriers, get out of the way, and then let my recruiters recruit and do what they do best. So I'm not saying anything magical to these guys. The magic really is with the recruiters. They are selling this place. They love the community. They love the hospital, and it shows. So just huge shout out to the work that they're doing. Some of the things that we did to help align that focus a little bit better was just restructure some workflows and move certain bodies of work areas so that they could focus on just doing what they do best, and that's selling this place. Just showing the love that they have for it, and that's where the recruiting magic all happens. So I'm just in the background pulling the levers, but they're the ones that are really creating the magic. So really all praise goes to them and their coordination with the clinics. That is where the magic is happening. Metrics are still on par. We did ramp up our student presence as well. So Kyle is still firing on all cylinders. I'm excited to see the work that he'll be doing. We have a new individual, with Crystal's team, who is a guru with community outreach and particularly with student relationship development. So I'm excited to see what those two come up with in the coming months and years. So we are seeing quite a bit of an uptick in our student presence here as well. And yeah, the metrics are running strong. We are knee deep in our UKG foundational work for a new HRIS system. We did have to extend it by about 3 months just to make sure that we could ensure that our scheduling was done well. We are moving 3 different platforms to one universal platform, and I don't want my nurses to hate us if our scheduling is messed up. I really want our directors to feel good about it. So we took a little extra time to make sure that they feel really good about the scheduling integrations with that. So that is all I have for HR, unless you guys have any questions.
Sorry, I missed the UKG bill. Yeah, that is huge. Absolutely.
Any questions? Virginia? Hearing none. Thank you. All right, moving on to operations. Since Holly, you've had 2 or so days to be here and get explained, what do you got for us?
Well, I'm just looking over the patient care services report. Looks like ED continues to see growth, about 48 patients per day, both in October and November. And they're on track for about 3.4% growth in volume from last year. So that's good. Some good things that have been happening in the ED, thanks to Amy Bloodworth from Cardiopulmonary for setting up an in-service for the staff, and I think it was well attended. Also, Cody has been working with charge nurses weekly to develop some charge nurse guide and other things, standards of care in the ED. He's done a great job in making sure that's happening. Also seeing an average of about 50 patients per day in the urgent care. And so that's good. There has been a couple of times where they haven't had the staff that they've needed up there and they've had to close. So they're hoping to solidify their staffing challenges in the next few.
Do we have any idea how much notice they give the public it's going to be closed, or is it just put a sign up on the door?
I don't know that. Do you know that?
It's usually same day or hour to hour when that happens. Cody is really working hard to come up with a more robust
Yeah.
staffing model for it, and love the creativity that Cody came up with
Yeah.
for that. So it'll take some time to roll out, but we will have a more robust model.
Surgical outpatient, beautiful facility down there. I've been very impressed. They've been able to hire and onboard. What staff wouldn't want to go down and work in that area? She's also had some challenges with unfilled open positions in the OR, but that's pretty typical for this time of year. So hopefully after the first of the year, we've also talked about some travelers. So I'll continue to work with her on that. And then family birthplace, they have some challenges for open night shift positions too. Looking into providing nitrous oxide as an option for pain management, which is exciting. And then food nutrition services, they've been able to backfill some positions. They've also did a contract renewal with East Adams County and Ritzville, and then providing temporary coverage in December for Leavenworth, which is good. Clinical excellence, as you know, we have a new manager. I think the staff are really excited and hungry for consistent education and growth in their professional development. So I'm looking forward to helping make that happen. Any questions for me?
Any questions?
Welcome.
Yeah, again, welcome.
Thank you.
Thank you. All right, moving on to Rhonda, Chief Ancillary Officer. Rhonda, are you online there?
Yes, I am.
Good. What
My
do you got for
report,
us?
my report is on page 36, and I think probably my only update is how excited we are to have the Radio Hill expansion. We have been growing in community-based services, as you can see from my report, and we have three new staff members working, and so they are going through orientation, and their space is very crowded. So we're having to get pretty creative on where we can put people to do their work and train them. So we'll be really happy to be able to have that Radio Hill expansion. Other than that, I don't have any updates, but I'm open to any questions you might have.
Any questions for Rhonda?
I think this also marks 1 year that Ron has been the superintendent at Hospital District 2. So it's been a good partnership, and District 2, it does have its own unique challenges, and an awesome group, awesome board, awesome staff, and the mission that they serve up there.
That's true. 1 year.
Ron, I was gonna ask about the pharmacy, the PCA pumps. Can you tell me what those are and what we're gonna do about the end of life situation?
Yeah, so they're ordered by surgeons typically to as a pain management method after a patient has surgery. So they can put the patient kind of on a baseline drip that they're getting, but they can also, the PCA is patient controlled analgesia, so they can push the button if they feel like they need more of a dose than what they're getting. Those pumps were completely at end of life. We can't get the glass tubes, the syringes that we use anymore. So we had 5 CAD pumps that were donated to hospice by the foundation, which we do use, but not real frequently. And so we will be able to put those into a PCA mode and use those instead. So at this point, we don't think we will have to purchase anything to replace those.
Thank you.
Mhm.
Questions for Rhonda? All right, Rhonda, thank you for your report. Appreciate it.
Thank you.
All right. Moving on to Jesse, standing in for Stacy, Chief of Clinic Operations.
Hi, yeah, thank you. Stacy's been out for 3 weeks and she's out for 3 more weeks. So I've been standing in place for her. There's a lot of exciting things going on in the clinics. It's probably going to sound like a reiteration of what Jason has said, but we have 2 new service lines that are going to be starting. So we have podiatry that's going to open in January, start seeing patients that second week of January. And then we have urology that is set to open in, which is super exciting. Some other highlights are, I was counting through my report and there's been 8 new providers that are starting. Like Dr. Rubin starting in vascular. We have certified nurse midwife starting in women's health. A nurse practitioner starting in women's health. We have 2 doctors that will be starting podiatry together. We have just a lot of new folks starting in the clinics, which is super exciting. To also wanted to highlight that Sarah Henniges, she's going to be leaving Family Medicine Cleveland, but she does plan to come back. So January is going to be her last day, but she does plan to come back sometime in the future. And then one other is Sarah Charlton of Pediatrics. She's going to be going on leave in January as well, but we will have a pediatrician starting the same month. So lots of exciting things going on in the clinics. Like I said, Family Medicine Cleveland, that's another light. They are working with architects for a redesign of the clinic. So that's also happening. So any questions for me about what's going on in clinics?
Any questions?
Where's podiatry going to be located?
In orthopedics. Yeah.
Okay.
Yeah.
Yeah, they'll be on the eastern wing of orthopedics. There's orthopedics is on the rest of the building. And podiatry also utilizes X-ray, hopefully, so having X-ray in their shared location.
That's
good.
Else?
Good. Anything else for us?
No.
Thank
Thank
you.
you. Thanks
Appreciate
for
it.
having me.
All right. So moving on to medical staff, Chief of Staff, Dr. Hoppy.
There, good evening. Can you guys hear me?
Yes.
Good, excellent. My report is on page, I believe 41. Just a couple quick announcements. We had a very well-attended all-staff meeting in November. So I'm very happy to see there were a lot of providers that attended that meeting. That's our annual meeting. A lot of new people there. People were engaged. And so everyone felt very enthusiastic after that meeting. Also, we're on target to have our bylaws revised by first quarter of next year. And so I'm working together closely with Dr. Thomas, Dr. Beard, and putting the finishing touches on those bylaws. So we're happy to report that those should be done first quarter of next year. And this month we had a very short credentialing report. We had, I think, 6 people that had initial appointments and 6 that had reappointments that were approved by the medical executive committee this month. So it was relatively short list this time around. So, but I'm happy to answer any questions.
Any questions for Dr. Hoppy? And I'd assume you'd entertain a motion to approve the medical list.
Absolutely.
So moved by Bob, second by Terry. Any further discussion? All in favor, say aye.
Aye.
I too will vote aye. Anyone opposed? That motion passes. And I just want to say, Matt and I are on the MEC and get to observe the work on the bylaws. And again, I just really appreciate the thoughtfulness that goes into literally every word in those documents and the effort. And I know behind the scenes, it takes a tremendous amount of effort to do that. So thank you for you and, everyone involved in doing that. We really appreciate the efforts there. So
Shout out Jen and Carlson. She is
very true.
phenomenal
Yeah.
keeping all that organized. There is a lot of things.
Especially on those months where we have 20 some
Yeah.
credentialing files to go through and whatnot. So thank you, Dr. Hoppy. Anything else for us?
That's it. Thank you.
All right, thank you. All right, moving on to Chief Medical Officer, Dr. Thomas.
Thank you very much. My report begins on page 42. I do have one addition I'd like to point out. Medical staff services, speaking of Shannon Carlson and her leadership, were successful in passing a very important multi-plan delegated audit that they went through on Wednesday. So congratulations to them. Be happy to answer any questions you might have.
Questions for Dr. Thomas?
And these are audits that insurance companies will do at random of our credentialing process. So we always welcome them and they're always, chins on
Flying
this.
colors.
So
Good.
wonderful.
We'd like to hear.
Yeah.
What's the current atmosphere out there for recruitment of primarily physicians, and still pretty competitive?
Yeah, absolutely. There are a number of specialties in which it is near impossible to find recruits. One example would be urology, and we've been fortunate enough to be presented with multiple applicants. So I think that that just goes to show the hard work that the recruiting team has done and the benefit of networking with our partners and recruiting firms who are helping to bring us quality candidates. Particularly, we know that there's a great need in our community for access to primary care. That continues to be an area where recruiting physicians is difficult, but we've had better luck recruiting advanced practice clinicians. So we've been successful in keeping the clinics fairly well staffed, and we're very grateful for the recent starts of physicians like George Lupus and Sierra DeLay up in Cleveland. So,
As far as like urology goes, since that's going to be a startup, is that a positive for recruitment? If somebody who's a little bit more ambitious is like, I get to make it my own, or?
yeah, it might be. It's also creates a bit of a selection bias because there are certain providers who are quite content in a busy, bustling, organized practice and not ready to take on the responsibilities of being a sole provider. But I think that the candidates that we've been presented with, and particularly the one that we're interviewing tomorrow, are very well suited to take on that responsibility and help us craft a mature program, even with a small number of providers.
Good. Any other questions for Dr. Thomas? Anything else for us?
Nothing else to add.
All right, thank you very much.
Thank you.
All right, so we are moving on to Chief Financial Officer, Jennifer.
Good evening. My report starts on page 44, sorry. Just a couple of things to note in my financial summary. I mistakenly put $22,000 over 2024, and it should have been an M. So $22 million over 2024 gross charges.
What's up?
What? Oh. Woo-hoo.
Somebody's excited to hear that his number.
And so then my my KPI dashboard here, we're kind of going with how it should look going forward, but a couple things to mention. Our revenue cycle team with their strategic goals will be looking at an indicator called revenue cycle effectiveness score. That includes their denials, their days AR, and some other things. And so they've exceeded the target that I gave to them already. So we're gonna have to look at that again for next year and make sure that they have something to go for. Another one is the budget variance management, which it doesn't have a trend because that's new. Just staying at 1.5% to budget is a target we'll be looking at. And then I made a mistake on the emergency room visits. That should have been backward. That should have been yellow.
That
So
explains it.
yeah. Shouldn't have been yellow, sorry. Should be green. And then if there, I'll just, answer any questions. If you have any questions, we're going to talk about the x-ray machines a little later and the arthritis calories a little later. And can move on to financials if you don't have any.
Any questions for the first section?
I'll just move straight to the income statement unless you want to talk about this.
No, that's fine.
Okay. So revenue was up. Again, our deductions are pretty conservative, and which brings the net revenue down more than you would think with such high revenues. So, but year to date, we're really close to budget on our total operating revenue at just $27,000 under budget. So pretty good. Then as always, we're looking at professional fees. We split out supplies from pharmaceuticals because we really want to be measuring how we're doing with the GPO. Bonnie does such a great job with watching the purchases and managing that. And then we can also see the shenanigans of the pharmaceutical company. And what they're doing with the 340B program is really what you're seeing there on pharmaceutical overages from budget. Purchase services are over. We had that depreciation that kind of brought us back closer to budget in expenses, but I would note that our revenue is 1% over budget and also our expenses are 1% over budget. So that's pretty good. Any questions there that I missed?
Questions? No.
Okay. I'll move on to the balance sheet, and this is kind of a new thing I asked that I added is last month. So last month, because we kind of want to, operationally see what happens month to month. Last year at this time. So kind of some things to point out would be down the line at plant, property, equipment. We have spent almost $10 million, which was the amount of the revenue grant, revenue bond, on expansion projects. Also the ortho and let's see, anything else? Balance sheet doesn't really change too much, but if we go to the cash flow, we can see from the beginning of the year how we've spent. So from operations, we have taken in $12 million positive. And then as we take our cash balance down, we can see our current assets involving patient accounts and other receivables kind of change your balance. We moved this $4.8 million to investments, which is why it comes out of the cash flow statement for operations. And then there's that 9.6 million in property and equipment, and everything else is just sort of minimal, showing our balance at the end. So our ending cash on hand, 3.5 million, not include investments. Questions? Love it when the eyes just go.
We gotta go to Rotary. 10 questions.
Really?
Yeah, Rotary.
It's like, let me talk about the financials. Okay. AR days is a little bit higher than maybe I might want to see it in that the hospital total, mostly self-pay there in that large late bucket. So we're doing some cleanup there. And you'll also see it increase a little bit over time as we implement our credit balance policy and getting rid of some of those credit balance. But I think they're doing a really great job. They are at 55.5 days, which is comfortable.
When did you start putting in this detailed AR date?
I don't know.
About 2 years ago.
I didn't do it.
I don't know. It's pretty interesting to see how this breaks down.
So we're gonna introduce some KPIs about aging and like gonna have a target about over 365, days. So do that. That'll be fun. I think the revenue cycle team is about their strategic plan. And then there's our investments and still just working on Jason's methodology of having investments mature at the time where our debts are due. And that is that. As far as financials go, and I think we can move on unless there are any questions to capital.
Good to move on.
Okay. Arthur's Towers, I don't think we have Amy here. We had Amy at our finance meeting.
Are you talking about Amy Bloodwood?
No.
Roxanne. She attended our finance committee meeting and presented and asked the committee to recommend purchase of the Arthrex towers for surgery.
So these are video towers in each physical rooms. This will make them have the same towers in all of the rooms. A lot of this equipment was purchased in 2020 and some in 2024. But it went live in our system here in 2025. We just purchased it earlier. So that newer stuff is going to get traded in, and then the older stuff is really at its end of life and it's starting to sag and fold. It's causing providers to manipulate the equipment for a little bit while they're in there before it's set in position for them to start their surgery. So Bob and John had the opportunity to meet with Amy as well during the finance committee to talk about this. It's an absolute workhorse equipment. Every one of our surgical modalities does use it: orthopedics, ENT, general surgery, podiatry, gynecology.
So John and Bob, you have any, what are your thoughts?
Yeah, we definitely support it. It's a little frustrating from a timing standpoint, since this is electronic based equipment. It fails quicker than physical equipment. But the fact is, we can't have our surgeons being delayed trying to get equipment to work with the patient ready to go into a procedure. So it's just it's a necessary evil, needs to be done. And the feeling is it brings them all uniform, up to date, gives us a new 5-year kind of ticking clock, a piece of equipment that depreciates very quickly. So
yeah, Amy brought up this equipment depreciates quite a faster analogy, kind of referred it to like your cell phone. So you buy a cell phone now, in 3 years, you're 4 versions behind, and it does start depreciating rather rapidly how much it's used.
So the finance committee, and Bob, you can speak to this too, after a long discussion, definitely reached the point where we wanted to move towards the whole with our support. So
Yeah, I agree. I mean, the easy decision.
yeah, I wish the numbers were smaller, but yeah, medical stuff's expensive. So
they were Bonnie.
Yeah, and again, when Bonnie tells me what she starts at, what she ends at, I always feel a little bit better. So
You gotta remember to start at the beginning, start at the end.
yeah, because I believe this she got almost half off. I
Yeah.
think by the time she negotiated the price.
Yeah.
They are so negotiable.
So yeah, so I think we support it.
Do we both?
We do we do a motion when anyone's so inclined?
I'll move to approve it.
Okay, motion by Matt. Second by Bob. Any further discussion? So all in favor of approving the capital expenditure for the Anthrax Towers, say aye.
Aye.
I too vote aye. Anyone opposed? That motion passes.
Okay, and then we have another one. I'm sorry, it wasn't in the original board packet. It ended up being a little bit of an emergency here as our ED portable machine went down. John and I believe Bob were also able to meet with Kimmy and have her show them around. But Kimmy, do you want to?
I appreciate you coming. I think we had some really good conversations, short term, mid and long term, but I don't know if you have any further questions related to that, but the portable units are our most rudimentary first line X-ray response. These units we take to bedside for traumas. If something goes wrong in surgery, that is the equipment that the technologists take right to the patient. And the units that we have are end of life. They quite appreciate it. We have an opportunity to do an uplift, keep the housing of our current units and save ourselves pretty close to, well, around $200,000 if we do that and make what we have new with this purchase. I think it's a smart way to go. We were able to leverage the price down. GE, we're such a good customer, and yeah, a little bit of good negotiating.
Machines went down this last weekend, and yeah, I think this is pretty basic that we need to have mobile X-ray machines up and running. Yeah, inconvenience to the staff, more so the inconvenience for the patients. We move to down the hall versus the X-ray coming in to them is pretty excessive too.
Yeah, and I want to, thank Kimmy. Let me come and ask endless numbers of questions, and you just kept finding, give me the answers. So I really appreciate that. It helps me so much more to see what you're talking about. And like you said, we're keeping the physical hardware and upgrading the inside to modern day state of the art at a much more economical price. I think it's fair warning to the 2 rooms that we have that are available for X-ray. I think in short order also need to be upgraded, bring them all present day state of the art. We can do all that for including this for less than $1 million. And we anticipate like approximately a 10-year lifespan. So at less than $100,000 a year, it's just such a fundamental tool for medicine. We just need to make sure we have redundancy and the equipment's there and functioning when a patient needs it, because we don't want them to have to wait. So I think for this one, particularly the starting point, the upgrading the 2 portables is a very worthwhile thing, and I fully support that. So absolutely.
Yeah, this equipment was purchased, I believe, 2017, and a whole bunch of our equipment in radiology was purchased in 2017. That was when Julie came on and she leased out all of this new equipment from GE in 2017. So we're going to see a lot of this equipment coming due around the same time. So Kimmy will be bringing more things to come. I even just walked through the department today and somebody was like, how about a new echo machine too? So anticipate more to come in the radiology area. Definitely this equipment has got its life used out of it. And thank you, Kimmy, for keeping it up and running so long.
And I think as an institution, we've agreed to move away from leasing and just work on purchasing so that we control the long-term costs and stuff. So.
Was it like was it like a buyout at the end?
Yeah, so we leased them for, I believe they were 5 leases or 4-year leases, and then we bought out the leases as we became more financially stable and had that capital to buy out. Yep.
It's my understanding that all the X-ray systems are fully depreciated now. They're at end of life and stuff. So.
Yeah. Some we have a little bit left. We'll squeeze every bit we can now.
Yeah. So if there's no more questions, when ready, if anybody's so inclined, I'll entertain a motion. Vote to approve.
Second.
Motion and second. Any further discussion? So all in favor of approving the capital expense for the portable X-ray units, say aye.
Aye.
Aye. I too will vote aye. Anyone opposed? That motion passes.
One more thing for me. This is resolution number 2512. And this is something you do every year to amend the expense part of the budget. Even though our revenue with our expenses still are projected to be about that 1% over. So we're asking to amend the budget by 1.5 million to a total of 150 million, just over 150 million.
Okay, and I think this is pretty standard every year. When we grow quicker than we expect, we end up with additional expenses, but we also have additional income to offset that. So does anyone have any questions or concerns? So I think we want a motion for this also. So
I'll move.
okay. Motion by Terry. Second by Bob. Any further discussion? So all in favor of approving resolution number 25-12, say aye.
Aye.
I too will vote aye. Anyone opposed? That motion passes.
I think that's it
Is
from.
that it for finance?
Thank
Okay.
you. My questions.
No, I do not have any questions. Anybody have any other questions for Jennifer? Thank you, appreciate it. So, I don't see anything related to, marketing here, so.
That one, just hold for a minute till you step back on the one.
Oh, okay.
We can talk if we need to.
Yeah, and this is often a place where everyone who's suffered through this portion of the meeting, do not feel bad if anybody wants to call it a night and whatnot. We're gonna go on to just some standard board business, and then we'll go into executive session shortly thereafter. So anyone who wants to is welcome to depart without us making fun of you. Thanks, Kimmy, appreciate it.
Appreciate your
Kimmy.
time.
Good evening and that.
Yeah, seriously, anybody on a leadership team that doesn't have any other business. Block.
Oh, it's not.
Thank you, guys. Well, you would step out and just give people a chance to step out without interrupting the meeting. So, all right, we are ready to carry on with old business. At the previous meeting, we brought up the 8th annual hospital advocacy days in Olympia.
Sign that one.
And so we hadn't quite finished the discussion of who would be in the best interest of the hospital to attend that meeting. So lost the board member. Yeah.
That's the one in Olympia.
That is the one in Olympia, yeah.
I'd like to go, but I've also heard that there was 2 other commissioners that wanted to go.
Yeah. Oh, go ahead, Matt.
No, I think, yeah, Bob and Erica haven't gone recently, so I think I'm supportive of them going.
And I think it's really important that CEO be one of the 3 members allowed to attend and continue to build FaceTime and relationships with the leadership in Olympia. So as Matt said, I would support Bob and Erica if, and we're confident she's still interested as far as we know.
I'll support Bob and Erica also, but if Bob or Erica don't want to go, I would take one of their positions.
Okay, I'm
alternate, yeah.
Yeah, it's an alternate. So yeah, and we'll just confirm with Erica in the weeks to come that she fits her schedule and whatnot. So is there any further concern or any discussion about this? It would be Jason, Bob, and Erica as the 3 that we would nominate to attend on behalf of KVH.
And no motion or anything, it's
Yep.
not because it's not out of state or anything, you guys don't have to do anything, I just needed to.
Yeah,
I'd like for 2 to join me, it was a good opportunity last year, I thank Matt and John for joining me last year for that, and meeting with everybody, and look forward to doing that this year, Bob and Erica and Terry as well.
Excellent. So good. That sounds good. So we're moving on to 9, new business. We have resolution 2511 that is required related to our 2026 KVH Board of Commissioners meeting schedule. So you all should have a printout of January through December of the various dates. Usually it's the 4th Thursday of every month, with the exception occasionally in November December because of the holidays there, we switched a little bit. So does anybody have any thoughts or concerns about the schedule that was provided?
Concerns?
So that calendar looks good. I will entertain a motion to approve this resolution when ready.
So moved.
Yeah, okay, moved and seconded. Any further discussion? So all in favor of approving resolution number 25-11, say aye.
Aye.
Aye. I too will vote aye. Anyone opposed? That motion passes. And we're on to board officers. We've not really discussed that. Is there any, usually we go in 2-year cycles. Not sure if anybody wants to suggest a change or any concerns or.
I like the idea of the 2-year cycles. So if there are no objections, I'd like to put forward a slate of officers. So to continue, John Ward as president, Bob Davis, vice president, and Terry Clark as secretary. So I'd like to put that forward as a motion.
Any other proposals or discussions for this? So we have a motion with no other discussion. If there's a second, we'll move forward.
Second.
Motion and second. Any further discussion about the proposal that Matt put forward?
Who made the motion? Sorry.
I made the motion.
Yeah. Second by Bob. Hearing none, all in favor of the slate of board officers that Matt put forward, say aye.
Aye.
I too vote aye. Anyone opposed? That motion passes. Next, we are to board committees. So we have the 2025, and again, we can continue with a 2-year cycle or entertain any other suggested changes. Who wants to suggest anything?
I'd like to, if no one has any objections, I'd like to continue the committee assignments that we had in 2025 into 2026. We can't always revisit this when we're in 2026, but I think it's working out well. I don't think there's any reason to change it. So I'll, if people are good with that, if I don't hear any objections or anything, then I would like to make a motion to approve that membership list that would just carry over from 2025.
I'm on the compliance. And I would like to be on one of the other committees. If somebody thinks that would be okay.
Yeah, I think the idea is that it'd be good to get this in place and then we can always revisit it in a couple of months. I think that's the idea.
Okay, that's very good now. Thank you.
And I enjoy being on the finance committee. I would ask Bob if he would like to chair it this upcoming year, or I'm open to whatever you think is best.
Don, you did a great job.
But it's fine. Okay, good. So Matt, you want to put that forward as an official motion just to carry forward with all of the same that it is for 2025?
Yes, I'd like to make that motion.
Okay. Is there a second? Second by Bob. Any further discussion? Hearing none, all in favor of continuing with the committee assignments for 2026, say aye.
Aye.
I too will vote aye. Any opposed? That motion passes. Next, we have board calendar. That's just information, which is just informational. So very good. And just notice that we have a couple of out-of-state events next year, and at some point, any of the members who are thinking about going should just bring it to the attention of the board, and we can just make sure that it makes sense and do any approving that we have to do as presented and whatnot. So I'm not sure if you want to talk about rural or anything, because that's the one that comes up the quickest in early February. Anyone's thinking about it, conference, and whether wants to discuss it now, or we can do it at the next meeting.
Yeah, I'd prefer to maybe wait unless anybody has any burning desire.
Yeah, I'm okay with waiting. See what Eric is thinking.
Yeah, that's perfect. So there's no urgency to that, and it doesn't need to be voted on at this point. So just be aware the calendar exists. If you have any thoughts in the future, let us know to make any adjustments as needed. So is there any other new business needs to be attended to by the board?
I would just note on the calendar, so throw on your calendars, June 13th, 4 p.m. for the foundation annual fundraiser. We're gonna pivot and bring it up to Cle Elum this year. So really excited to see the foundation doing that. For the Cle Elum and Richard County.
And you said June 13th?
It's on page 2 on the calendar.
I've already got it over
Order
there.
of it.
Yeah.
Excellent, thank you. It's so noted.
And shout out to Laura with the foundation this last year. She brought in $630,000 was the total contribution from the foundation this year to the hospital. Huge number. We really try to spread it across the organization from Lower County to Upper County, including $200,000 that the board authorized to pass through to Hospital District 2 for a new ambulance up there. They do have that new ambulance. It's pretty uniquely beautiful how they did the graphics on it. If anybody has interest in going up there sometime to come get a little tour as well. But yeah, shout out to Laura.
And I saw Jason got a little time on the Yakima News, talking about the money coming in and being dispersed.
Yep,
stuff,
and
so.
the Daily Record, I heard we were on the front page as well.
Yep, well, impressive, good. All right, so we have executive session. We've got personnel issues to talk about in executive session. Do we know how much time we want for executive session? And who's going to attend that? Then Crystal will attend. Is there anyone else who's going to attend?
And Holly was gonna attend.
Holly's going to attend, okay. And I don't think we need anyone else for this session. And then probably we'll dismiss you two, and the 5 board members will have a subset discussion. So I'm thinking we probably need 60 minutes start, and we'll extend as needed based on how the conversations go and stuff. So it is 6:46 right now. So we'll take a 4-minute break, and then we'll reconvene at 6:50 with a 60-minute executive session extended as needed. So thank you everyone for attending, and we will come back into public session. Do we expect any votes or anything? We'll come back into public session.
John, can you read number 10 on the amended agenda?
Recess in executive session to evaluate the qualifications of an applicant for public employment and to review the performance of a public employee under RCW 42.30.110 subset 1 subset G, and discuss with legal counsel the legal risks of a proposed action or current practice under RC 42.30.110 subset 1 subset I. Is that what you needed?
Thank you.
Good, thank you. All right, so we will take a 3-minute break and start executive session at 6:50. When we come back into public session, there will be no business. Thank you.
Quick introduction, Natalie Curtis here as well. She's our new providers in internal adult medicine and has been real rough in that.
That was right.
You want to call out
Oh, that was.
Thank you.
intro to Natalie.
Also a member of our excellent recruiting team, I want to add. So, yeah, she's working hard.
Bringing in referrals.
Okay.
Yep,
Thank you, Natalie.
that was the agenda.
That's okay. Thanks.
You're welcome.
We saved money by in there what we spent, so.
Yes. Yes.
I will continue.
Like, have it. Great.
Okay.
Yeah, I think you did good. Thanks.